Did you know FDA-approved Vyvgart, efgartigimod alpha FCAB, is available for your adult patients? Visit vyvgarthcp.com to see the data and explore how it works. Vyvgart is a registered trademark of argenx.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, I'm Derek Stitt, neurologist at Mayo Clinic. This podcast episode is one you're going to keep in your podcast Rolodex, especially for those who do any critical care or acute inpatient neurology. But even if not, then still stay tuned because we touch on some points that are important and potentially eye-opening when it comes to how we think and talk about consciousness and responsiveness in those with significant brain injury. I am delighted to be joined by Karin Diserens, neurologist and acute neurorehab specialist at the Lausanne University Hospital, aka the CHUV, in Switzerland. One of Karin's areas of focus is consciousness assessment in those with critical brain injury, and she's here to talk about what I think is a very enlightening and motivating paper published in the Green Journal. It's in the Contemporary Issues section, came out in late February, titled A Focus on Subtle Signs and Motor Behavior to Unveil Awareness in Unresponsive Brain Injured Patients, The Importance of Being Clinical. I thought this was a really well-designed article, and you start out the article with some helpful introduction and background on the landscape of consciousness assessment in those with severe brain injury and how difficult it can be. And I'm going to quote a line from your intro that I thought was really nicely distilled. It said that proving that an unresponsive patient is aware is hard, but proving that the patient is lacking awareness is harder, if not impossible. And so I was hoping you could start us off by giving us some background on the status quo of consciousness assessment. We can talk about where things were before you've proposed these new tools and this new flow sheet, and then we can get into what your group is advocating for.
One of the main problems is that the definitions of types of disorders of consciousness is not the same in every country. The Glasgow scale we're using each day, and indeed it's really quantifying only motor and verbal responses. However, some brain injury patients show a lack of command following using conventional neurobehavioral examination tools, but have a high level of awareness and capacity of language processing. Nevertheless, because of their behavioral unresponsiveness, cognitive motor dissociation patients appear clinical indistinguishable from those with the true disorders of consciousness and are therefore misdiagnosed. Why do you need these clinical evaluation? Why it's so important? And in this respect, diagnosis should not be limited to these standard clinical scores that we realized. And that was our motivation. Our observations were that assessing patients using the standard clinical scales, as I said before, only quantifying motricity and verbal command response, patients formed one group. Yes, we applied these scores, and we had one group with the same scores based on the Glasgow 4 and clinical scales. However, during the first evaluation in the intensive care, we differentiated two different types of motor behavior. One set of patients had akinetic motor behavior, and the other set had reflex movements and decortication and deceleration motor pattern. Akinetic motor behavior patients showed subtle little signs of consciousness perception, meaning signs of interaction by intentional movements. The other set of patients essentially had reflex reactions. The focus of our research, therefore, aims to expand the range of motor testing across limb, facial, and ocular motricity, allowing detection of subtle, purposeful movements. Even in the subset of patients classified as vegetative, we developed a new clinical tool for this that we call the motor behavior tool. Our observation was the subtle signs of conscious perceptions were in most cases associated with the characteristic of akinetic motor behavior as opposed to a pyramidal motor system behavior. We proposed the term of clinical cognitive motor dissociation in order to describe patients showing slight but determined motor responses. So we elaborated a flowchart And the diagnostic flowchart compares the clinical examination with the results of structural imaging and neurophysiological examinations in order to search for neurological deficit intrinsically to the brain injury process and interfering with the production of appropriate behavior motor responses. It means we looked to have lesions in the strategic localization of brain responsible for motor planning or peripheral lesions responsible for motor responses. So strengthening the clinical evaluation by observing the motor behavior complemented by assessment consisting of an MRI independent of task-related and command-following activity and task-independent potential recorded by EEG. That is a new approach for these patients.
I applaud you and your group for your work on developing these processes, which are quite detailed, but they provide great guidance for those out there assessing an unresponsive patient. But I was hoping you could tell us more about some of the bedside assessment tools that you mentioned in this paper, specifically the Motor Behavior Tool Revised, or the MBTR, because that's a big part of the flow sheet. And so I was hoping you could talk about this tool more specifically. And I should mention that this tool is meant to be an adjunct to the coma recovery scale as a complementary tool.
What we do, we observe the motor behavior meticulously. Looking at the negative signs, it means an array of reflexive behaviors and positive signs, which are subtle intentional movements. Sometimes you turn just around and the nurse say, hey, you see, he moved. And that is important to give the time to observe. The coma recovery scale says we have to be there 1 minute at least, and it's right. So this clinical neurobehavioral evaluation also integrates detecting pitfalls, and that's important to think to these pitfalls in the beginning of your examination. When we make the flowchart, it was difficult when we think about our pitfalls. So it's good when you're examining the patients, you think where could be pitfalls of the motor afferents. Using a flowchart, incorporating a search strategy for potential concomitant pitfalls are gaps, compromising the production of a motor response that would hinder the correct diagnosis. That can be central or peripheral. We do our activity as an interdisciplinary transversal team, evaluating the patient's minimum 24 hours after withdrawal of sedation and repeated 3 or 4 times a week to ascertain the clinical diagnosis. So that's a complement to the standard scales used in every hospital.
Thank you so much for that background and that explanation. And as you say, it really seems like it's all about being meticulous, and it is going to take time and time at the bedside and repeat visits, repeat assessments, but you can glean so much from doing that. It's certainly clear. That's a very helpful illustration. Now, it's not just this tool that you created, but you also outlined a very detailed flow sheet for assessing awareness. But first, I was hoping you could remind us about why it's important for us to assess for cognitive motor dissociation and what implications it seems to have regarding prognosis.
They are already in the acute phase a very big importance. Firstly, we should avoid considering an unresponsive patient as someone unaware with hidden cognitive capacities, which induces important suffering for the patient, the family, and the caregivers, and compromising an adequate treatment approach. The caregivers and the families are just more motivating the patients often to interact, and when we come by, they don't know us, they don't interact with us. Therefore, we have to believe them. And secondly, a detailed clinical assessment using the MBT tool combined with a systematic search for confounding factors makes it possible to determine an appropriate clinical diagnosis of the patient's level of consciousness and to prognose cognitive sequelae on the basis of the impairment revealed by the paraclinic examination. This is important when the families want to know what we can wait for, his deficits, how he will be in his dependence, that it's independent from consciousness. We have to know, we can anticipate with the local focal lesions what the patients could have of sure and less sure of deficits. And our recent publication of May 23 this year of the evaluation of the outcome of the patient after 1 year confirming that is a significant difference in improved outcome, a better motor output, and a considerable cognitive capacity was seen for patients compared to true disorders of consciousness. Nevertheless, it's only one of the arguments of the patient's life decision. That's important. We really have to take account from the individual goals, what the patients would like, what the culture of the family, and this is only one part to decide where we are going with the patient.
Our listeners, to really get the most out of this content, would be certainly best served by going in and checking out the article and looking at those figures firsthand, because they are detailed. But I think it would be helpful and illustrative if maybe you could give us a scenario, whether it be hypothetical or an actual case, where you employed this model and how it turned out. And then if you can, maybe talk about still some of the limitations that still exist with this enhanced bedside approach, because a lot of our listeners may really have limited access to resources, might just have standard MRI, EEG, and then the bedside exam. So if you could maybe give us a little bit of an example of real-world application, I think that would be helpful.
I will report one of the first cases we published also in 2015. And this was a 50-year-old woman in good health who presented headache and vomiting for a few days, was found unconscious by her husband during the night. The patient was intubated and transported by ambulance to the emergency room. Glasgow score was 4. She was immediately operated for an oligoandroglioma. We observed in intensive care an extubated akinetic patient with bilateral ptosis, with no intentional movement except for a slight non-reflexive movement of a finger, but no intentional opening of her eyes. In passive eye opening, there were no resistance, no oculomotricity, and no fixation. She was classified coma by both scales, Glasgow and Coma Recovery Scale. Based on her akinetic motor behavior and the slight intentional movement, which could translate a preserved cognition, we searched for pitfalls as to why the patient could not interact. On the MRI, we found the explanation of the dissociation between motor interaction and slight signs of conscious perception. Multiple ischemic lesions, principally mesencephalic ischemic lesions, one important lesion in the midbrain caudal region corresponding to the localization of the central caudal nucleus of the oculomotor nerve. Our patient first opened her eyelids after 3 months, when her akinetic mutism had improved and when she was walking and talking again, confirming that her unresponsiveness was due to blocked motor output rather than unconsciousness. And no disorders of consciousness patient would walk after 3 months independently. That was for us a very important experience, that once we have to look for the deficits, we have to look for the pitfalls, and which is important, we have a very good neuroradiological team. We have to ask them what we are looking for and where we suppose the lesions could be.
That was a great description. What a remarkable case. It was just the finger that provided the initial clues that then set up the rest of the evaluation that led to the discovery of the cognitive motor dissociation. And that's also a great point you make about being meticulous, not just in your examination, but then letting the radiologist know exactly what you're looking for so that you have the most interpretable results that are keyed into what you're looking for specifically, because it's really, really detailed when it comes down to it. So I appreciate that illustration. So I think to summarize for our listeners, I would say that what I've learned is, and what I've had reemphasized to me, is that detecting covert awareness is tough, but it does have prognostic implications that certainly make it worth looking for. And by practicing and using the motor behavioral tool, the coma recovery scale, working through the flow sheet from your paper, meticulous bedside examination, giving your time, you can detect awareness when it otherwise would be missed or otherwise required fancy testing to detect. That's a lot of times just completely inaccessible to some practicing neurologists. And so I think those were the big pearls that I gleaned from this article and from our discussion today. Does that sound okay, Karin? Any other points for the summary that I didn't touch on?
No, it's an excellent summary.
Karin, thanks so much for joining us. Everybody, go check out the article, especially the figures and the flow sheets. They're very, very well done and well synthesized. That'll be all for today. Thanks so much for listening. I'm Derek Stitt for the Neurology Podcast.
Thank you, Derek.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.